through a journey through FUSIC HD because that was the talk most people had requested. So my name's Samson. I'm an anaesthetic intensive care trainee in North East London. I have no declarations of interest. So just a bit of an outline of what we're going to talk about, why HD Echo as opposed to FUSIC HD Echo specifically, how to complete the FUSIC HD accreditation, a bit about beyond HD, so how FUSIC HD might compare to a level 2 Echo, a bit of discussion about governance and grey zones, and then just some considerations for those early adopters, which you may be. So in terms of just the first question, why do hemodynamic echo, or even why are we starting this project? So I think it's obvious that clinicians want to learn echo, and learning should be encouraged and supported, not gate-kept. And it's evident by the fact that 200 plus people out of the 300 plus people on the FICM training group joined FUSIC HD's WhatsApp group straight away, that people are interested. And I personally believe echo saves lives. I'm sure that can be debated, which we won't go into. I think that 5 years of medical school plus 2 years of foundation training plus 7 years ICM training is an absolute minimum of what it takes to become a consultant, should be more than enough to be able to learn some level of echo. I think accreditation is essential to protect everyone involved. That goes for the patients that you're using echo to diagnose and provide treatment for. That goes for yourself as a clinician who takes the responsibility for that. And that goes for your colleagues, because when you report an echo and to people who haven't done the echo or aren't accredited in echo, you would leave them exposed if you've made an error, which is obviously far more easy to do if you've not fully gone through the learning and accreditation process. And there's some protection, I guess, to an accreditation. I think equity is more important than equality. Most people would agree with that who work for the NHS. And it's actually quite hard to accredit in anything. So part of this project was just seeing how we could try and reduce some of those barriers, although we won't be able to reduce all of them. And I also think the responsibility of training shouldn't fall on enthusiasts, and it kind of does, because people are not job planned properly to be able to train people in echo. And people put in lots of time beyond their sort of work schedule to be able to train others, and there's just not enough people that are available to train people to reduce that burden. So we're just going to give some example of some cases. So it's the middle of the night, you're called from A&E because you've got a patient who's cold and shocked. They're acidotic, they've got a poor renal output and a nasty kidney injury, they've got a hepatic injury, and they've got some non-specific ST changes on their ECG, nothing to reassure you, nothing to specifically send you in any specific direction. And some fluid is started, which usually seems pretty sensible. And as soon as you see this patient, you notice that they are somewhere at the top of a very steep hill, maybe halfway down it, and you've got very little time to be able to turn them around. And it might even be made worse by the fact that you may have to anaesthetize them because of their deterioration in the coming short period of time. And I think that's a moment that all ICU trainees and medical and other areas of training have been through. But which is quite an anxiety-provoking place to be. And I think undifferentiated shock is probably the core area for where I think hemodynamic echo adds a lot. So you might find a patient with a large pericardial effusion, and you would have been able to spot that from learning sort of a FUSIC normal heart scan. But you can look a little bit further, look for RV collapse, look for some of the Doppler parameters to see how much you think the pericardial effusion is contributing to the hemodynamic consequences that you're seeing, or whether there's other causes of hemodynamic deterioration. Or with cardiogenic shock, I think I found when I was doing FUSIC heart, you would see a really severely impaired LV, and that could be a patient who's walking around and enjoying their life, or it could be a person who's significantly deteriorating in front of you. And sort of AHD kind of adds that additional bits of information, such as doing measuring their cardiac output through their VTI. and that'll help you differentiate from CCF, although there's other features you can look at too. RV failure is probably something a lot of you have seen before, and you see a patient with a big RV like this compressing their LV, and most of us want to know why. And it might be that you say do a bit more investigation, you measure or you estimate their pulmonary pressures by measuring the tricuspid regurg jet, and you see it's through the roof, and that might send you down a direction where you want to do a CTPA to look for a PE or whatever other thing you want to investigate for or treat as part of their pulmonary hypertensive crisis. Or likewise, you could find that same patient with RV failure where you find a regional wall motion abnormality in keeping with an RCA infarct and torrential TR as a result, and you measure their pressures, and maybe they're high, maybe they're normal, maybe they're even low. And it's putting all that information together through both the use of clinical acumen and hemodynamic echo that can prevent that patient from going down their RV spiral, and try and rescue them wherever they are along that way. Not that common to see, but when you do see it and you recognize it, this could really save someone's life. The patient who's got increasing inotropic requirements with systolic anterior motion of the mitral valve, a posterior directed MR jet, and turbulence through the LVOT. And that's a pattern that you would practice recognizing through accreditation. And then maybe you'd go and do a Doppler further down and see that they have these sort of dagger-shaped Doppler pattern. And valvulopathies are part of the FUSIC HD questions. It's an example of someone with aortic stenosis. So you can look at it, you can see that that's a sclerotic valve, but you can also get it into the right plane and measure it and see what the likelihood is of this being a severe aortic stenosis and therefore contributing to your hemodynamic instability. And then maybe that patient who's had 2 liters of fluid still hasn't had enough fluid and they just need some more fluid, and working out that it's not one of those other things, and then doing some additional assessments might be able to help you with that. It's hard to find patients when looking at the variation in their cardiac output from beat to beat is validated, but there are patients where it is, and the response to that might be either giving them a vasopressor or giving them some fluid, and putting all that information together to try and establish why someone is in shock and providing an appropriate treatment in regards to the cause is for me what FUSIC HD is about. Respiratory failure is probably the second other area, although there's lots of cases when you might find it useful. So a patient comes in cyanose, sweaty, and you do a chest x-ray and they've got patchy alveolar edema. You look on their chest and you see B lines everywhere, which indicates fluid. And then you think, well, that fluid is either going to be most likely coming from ARDS or from raised left atrial pressure, stroke, heart failure. So you can have a little look at their left atrium, see if it's dilated, maybe measure some Doppler measurements, or measure their tricuspid regurg jet as well, to put all of that information together in context and send yourself down an algorithm where you can find yourself either somewhat confident that this patient has raised left atrial pressure, in which case if they've got that x-ray, maybe you want to be offloading them, maybe you want to be transferring them to a cardiac center where they can get mechanical support, providing them some inotropes, etc. Or maybe you can say this is normal left atrial pressure, clinically this patient looks dry, I'm going to give them a bit more fluid, and have that confidence to know that you can make that decision in the patient with ARDS. Obviously, your personal experience of managing these conditions is going to be far beyond anything I could offer by this talk, and maybe far beyond anything I know as well. So it's all about clinical integration. It's about in the middle of the night or in the middle of the daytime, but whenever you come across that patient who's in a critically unwell state, putting all the information together that you acquire and trying to bring them back up the hill. It's just another component of the things you already do. So taking a history, doing a proper clinical exam, interpreting blood tests and imaging. Echo is just another component of that management. And these are the 10 HD questions. I'm not going to go through them because of time. So how to accredit. The biggest barriers that people are going to experience are probably the accreditation process as opposed to the motivation to want to do it. So First of all, you need to do 50 heart scans, FUSIC heart scans, and 50 lung scans. So you have to accredit in both FUSIC heart and lung before you can go through the accreditation process for HD. How long that takes, I can't really remember exactly how long I spent. I spent a number of years echoing people without accreditation and feeling very ambiguous about what to do with those findings. Always wanting to do these accreditations and struggling to find the time and motivation. But some people have said it can take 200 hours, some people less, some people more. A lot of it's about the learning process as opposed to just the logbook process. And anyway, once you've got through those, let's just go on to what you require for HD. So it's 50 scans more for HD. You need to have 20 of them to be directly supervised by a mentor or a trainer. And then just in terms of how you acquire that logbook. So for me, the maximum amount of scans I could do in a day was 5. I did do 8 in one day, and that was because I went around with some echo techs who were far faster than me. But in terms of the full scan and report, I wouldn't expect to get more than 5 in a day. And at the beginning, I could often only get 1 or 2 scans in a day. It all depends if you find good patients with good pathology, with good windows, where the echo machine is free and the nurses are happy for you to scan the patient at that time. And then, of course, you can do scans at work. And I found at the beginning that it took too long to do a scan for me to get many done at work. I would just end up doing incomplete scans, and that kind of I found that quite stressful, really, because you just end up having a half-done logbook that isn't functional. And then you've got to counter the time for reporting the scan and then having the scan supervised. And I would estimate it takes about 30 minutes for a supervisor to review a scan. And then at least probably double that for organising supervision. So total time, 5 minutes to register with ICS, 2 hours to watch their videos. You need to email ICS to find a supervisor if you don't have one. It's then a 1-day face-to-face course. The self-directed learning needs a little bit of weighting to it. I found when I started scanning, I didn't really understand what I was scanning well enough to be able to interpret the scans properly. And that was one of the reasons I had to start kind of repeat the logbook after some proper learning time. I would say an hour a day for 3 months might be a sort of a good amount of time to spend learning. Everyone will be coming from different positions. Some of you will have expertise in the sort of theory behind hemodynamic echo and the understanding of physiology. But for me, probably an hour a day for 3 months. I've shared a FUSIC HD peer guide that you can find on the WhatsApp group that we started, which goes through all the resources that I personally used and 2 colleagues who also who've also completed FUSIC HD. And I'd recommend you to go there to have a look at what sort of resources are useful. Ultimately, it's a fair bit of learning. Practice period. Well, if you do the learning really well and you attend a course after the learning, you do things in the right order, you won't need a practice period. But I myself needed one just to start getting my head around how to do it properly. And you could maybe try and squeeze that into work days. But once you get around to the scanning, maybe 10 to 20 full 9 to 5 days would cover it in terms of the reporting and the doing the full thing and finding the patients, etc. 30 minutes per supervision of a scan, so that's 25 hours if you very roughly estimate it. And then the exam itself takes 2 hours. The exam for us was scanning a model, doing an MCQ, and they would review our logbook. They may have video cases that you have to present at the next exam. Ultimately, it doesn't require very much preparation if you've done all the rest first properly. So the biggest barriers, number 1, and this is for all of us, me included, is finding the time, the energy, and planning it properly. And this is a picture of my lovely cat after a meal, and that is often how it can make me feel when I think about all the time it takes to set yourself up for something like this. And then the other thing, which is the elephant in the room, and this thing we really can't help with, unfortunately, at the moment, through that WhatsApp group, is finding a supervisor. And they're few and far between, and they're all very busy people who often haven't normally been properly job planned to provide that supervision. So question is can you use your EDT days? I used 6 EDT days over a 6-month period. I was very lucky. I will pay homage to Whipps Cross Hospital for allowing me to do that. And I used them all over a 6-week period to get all my scans done. I I don't think you could. I think you'd really struggle to get all this done without coming in on non-clinical days. And EDT days are a source, but you might find that they don't allow you to use them locally. You're meant to be able to get 4 hours a week in stage 3, 2 hours a week in stage 1 and 2. So that is either 1 or 2 days per month. Theoretically, you're in the intensive care training manual says that you can use EDT days for special interest areas, which it wouldn't be a special interest area, I guess, or special skills area if you've not done an SSY in it. I don't know how fluid that is, but in my case it was, and I would recommend trying to use EDT days. And then maybe also using study days. This is a form of study, so why wouldn't we be able to do this in our study days? And we'll be doing a survey at the end of this talk so that we can try and get everyone's opinion on that and maybe send it to FICM to support the incorporation into the curriculum. So choosing a time, I'd say you need 6 months, preferably a new placement for a fresh start with lots of leave left to take, no other exams. I wouldn't recommend doing it whilst trying to take on the FICM. Obviously life considerations, you've all got your busy lives and fun things to do outside of work. Maybe picking a time with bad weather. Normally I would have said the winter, but maybe this summer would have been a good one. And then maybe when you're in a less busy ICU or a better staffed ICU that's conducive to having a bit of time to learn whilst you're on shift. You could, of course, consider going the full length and doing an SSY or a fellowship in Echo, and then there's a whole host of different accreditations that you could choose from. FUSIC HG is just one of them. I just want to mention attrition. So attrition rates from FICE have been reported up to 95% in some areas. It will very much vary based on the programs you're in. And there's many reasons for this and lots of barriers. And we all lead complex lives, and asking us to do this sort of stuff in our free time probably isn't reasonable, and maybe that's why. But it should just be a consideration for a trainer. So if you start training with somebody and you're one of those 95% or whatever percentage it is locally in your area, that could be quite disheartening for a trainer. So that's why I've recommended doing the learning first to know that you're ready to commit. And if you do the learning and you find you're not ready to commit, you'll still gain a lot from doing the learning. Just seeing where I'm on time. I'm okay for time. So I just want to talk a bit about how FUSIC HD compares to a level 2 echo. Was there any questions that anyone had right now, or should we save the questions for the end? It's just tell me if there's anything that people feel they really need to know right now.
There's a question asking how you become a supervisor for Vexus if you're already a supervisor for HD.
Okay. We'll save that one to the end. I'm probably not the right person to necessarily answer that question. But yeah, I'll take that one afterwards. I'll keep going, and then I'll give you guys time to ask anything.
I think I cut someone off who had a question.
Yeah, I don't know if you want to answer this at the end, but if you've got BSc level 1 and you want to do FUSIC HD, do you have to sit FICE, FUSIC lung and FUSIC heart, or can you use your BSc level 1?
I'm not sure. I'd have to double check because I think it's written in the guide. You probably would have to do lung. I don't know if you have to do heart. It wouldn't make sense that you would have to do heart because BSc level 1 is definitely beyond FUSIC heart. But yeah, I don't know exactly. I'll see if I can find it out, and I'll share it on the discussion group on WhatsApp.
Thanks.
No problem. So there we go. So for anyone who's not watched this video, you need to watch this video. This is the 2-hour FUSIC HD video that is on free on the internet for people to watch. Use this as a decider as whether or not you want to go through with the process. They ask on that question they ask on the video where trainees might think that HD sits along the spectrum. And it definitely sits somewhere in the middle. We're going to go through a little bit of how it compares to the other ones in the coming slides. So if we just take, for example, mitral regurgitation. So valves is one of the components of FUSIC HD. So the FUSIC HD manual in itself, there's a new accreditation, so I'm sure more stuff will be written, but at the moment it's a 9-page document to outline all the full data set for HD and what the things we are looking for on it are. And if you compare that to the BSE is a 50-page guide just on mitral regurg. So the amount of information available to you if you go down BSE level 2 is wildly different compared to FUSIC HD. And if you just compare a level 2 scan to a FUSIC HD scan, you can have a look. The X's all symbolize all symbolize areas or measurements or things that we'd look for on a level 2 scan that you wouldn't look for on a HD scan. So HD scan has less than half of those. And the things that we do look for, if we just say we take mitral valve morphology or LV size and function, then FUSIC HD wouldn't give you the full data set that you would acquire for BSE level 2. So it's safe to say that it's not the same or anything close in terms of assessing the valves. That being said, probably the most important thing to look for in a valvular disease is just the 2D morphology, and exactly how far down you go on to understanding the 2D morphology will be partly dependent on your own learning within that. Of course, I'm happy for someone else who knows more about echo than I do to challenge me on what I'm saying. But if we just look at what you are meant to look for in a HD scan, so you're looking at a 2D visual assessment, you're doing some colour Doppler to look at the sort of direction of flow of the Doppler trace, or the amount of colour going into the atrium, the characteristics of that colour flow. You're looking at the loading conditions of that patient, so that's both on echo and from your history and from reading through the notes and a clinical exam, etc., and taking that into context to decide whether or not this valvular disease is being under or overestimated by the loading conditions. You're doing a measurement for aortic stenosis, so you're doing the dimensional severity index. That's the only measurement we do that's specifically targeted at valvular severity, although we do measure E/A ratios that can be used as part of the context for other valvular diseases, for example, mitral disease. And then we're looking at the up and downstream effects. And I think this is probably, I find this that makes the most sense in terms of, what impact it's actually having on the patients. So, for example, if you take tricuspid regurg, you might see systolic flow reversal in the hepatic veins, and that's something you'd look for via a VEXA scan, even though a VEXA scan isn't specifically designed for assessing tricuspid regurg. Or if we're looking at aortic regurg, you'll look at the aorta and look for colour flow in the aorta. You might find diastolic flow reversal in the aorta. Note, this is the arch shown in my picture, and normally I think it meant to be the abdomen to really judge severity, but you get the drift. That being said, they mention in the guide that we do up and downstream effects, but if you're going to look at mitral regurg, probably most experts would say that you should be looking at pulmonary vein flow as part of that, but that isn't part of the data set. How essential that is or not is not for me to decide. I'm not an expert in echo. It's just a observation for me to make. But ultimately, you're doing 50 scans compared to 250 scans for a BSE level 2. And just acquiring expertise in echo because it's downloaded onto your brain is unlikely to be feasible. So it is fair that we're not going to be able to. You're not going to leave HD being an expert in valves. So what FUSIC HD doesn't offer, it doesn't offer answers beyond those 10 HD questions. It doesn't replace an advanced level 2 echo, and situations when that would be the appropriate sort of echo would be, for example, outpatient monitoring of CCF, grading someone's valvular disease, grading the diastolic dysfunction, ruling out infective endocarditis, although you'd need a TOE for that often, properly interrogating someone's mechanical heart valves, investigating congenital heart disease. These are all questions that are well beyond a HD scan. But there are some sort of grey zones, and I just want to talk about them. So I found that learning beyond the data set was really important for me, understanding what I actually was offering by doing a HD scan on somebody. If all you know is what's the limited HD data set that is offered, then knowing what would be, assessing the pre and post test probability for an individual patient following a scan or before and after a scan that you've done, and comparing that to what would happen if they get an immediate level 2 scan now, if they wait till the morning, and what's going to be offered by that scan, how confident you can be that the thing that you're looking for has really been found or disproven, I feel like requires knowledge beyond HD itself. So understanding beyond HD, that's fair game, but what about whether you calculate something beyond HD using your data set or measure something beyond the data set? You can see the color coordination I've done with that. So if we just take pulmonary hypertension, so an intensivist might want to know what's the risk that someone has pulmonary hypertension. They might want to know the mechanism. Is it pre or post capillary, or is it mixed? They might want to determine if it's acute or chronic, what class it was or subclass it was, the direct cause of it, the effects this has on the right ventricle, right atrium, RV-PA coupling, what impact it has on your cardiac output, what impact it has on your organ systems. They might want to decide on what treatment is appropriate and then assess the response to treatment, or maybe just decide whether this patient needs a PA catheter or not, and some specialist care. And if we just look at the HD data set, we assess the probability using TRV max. We look at the upstream effects, looking at the left atrial pressure, the mitral valve, the LV and the aortic valve. We assess the reliability of that TRV max, looking at the pulmonary valve, tricuspid valve, RV and RA. As an example, if you've got someone with pulmonary stenosis, you can't reliably use TRV max to assess pulmonary pressures. Or likewise, if you've got somebody with severe tricuspid regurgitation, then you may underestimate the severity of the pulmonary hypertension because of raised left atrial pressure and rapid equalization of pressures, just as an example. And we assess some of the downstream effects of pulmonary hypertension, so the effect that it has on those valves, on those cardiac chambers, or on the venous system to the organs using Vexus, and the LV function using stroke volume. But you could take some of these measurements. You could say, well, why don't we just put together the TAPSE and systolic pulmonary artery pressure estimate to assess RV-PA coupling, because that's something that's recommended in the ESC guidance, the European Society of Cardiology, in assessing the severity of pulmonary hypertension. Or you could do something fancy like measuring someone's EPLAR, which is just taking measurements that you've got from HD and putting them together to decide whether something, or to determine the risk of pre versus post capillary. Or maybe you could even measure something beyond HD. A lot of people, and I'm sure there'll be variability on this, would swear by pulmonary artery acceleration time as an important factor in measuring the risk of raised pulmonary venous resistance. I won't go through all of these on this page, but there's lots you could measure beyond what we've got in the HD data set. So the question is that the right thing to do, and what concerns one might have? So I guess the first thing to say is every new measurement or calculation requires a proper knowledge of its caveats, its pitfalls, and the criteria by which it's been validated. So you have to significantly extend your knowledge set by going beyond what's on HD. Of course, you can learn this, but then governance is the main issue. So it's not tested in the HD examination process, and it's not within the HD guidelines. So who's checking your work? So ultimately, the answer is probably you shouldn't measure. You definitely probably shouldn't measure, and it would be maybe less advisable to calculate beyond the HD data set, and probably you're going to get more out of going beyond, getting the most out of your actual data set. So really understanding the 2D assessments, etc. But I'm not saying this isn't advice. This is just me, the way, just the process that I've gone through when doing all the learning beyond, and realizing that I felt like I was missing out on some stuff and not really knowing what to do about it. So going beyond HD, I think understanding will benefit your patients, but I think probably calculating, measuring and recording beyond might not be advisable. But I'm hoping that some of the lower hanging fruit will be added later to the data set and will be taught as part of courses, for example, pulmonary artery acceleration time, just to name one that I've heard of before. And then just finally, some considerations for those early HD adopters. So there is limited trainers and supervisors, and this is probably the number one consideration, and that's been evidenced by the questions on the group, the questions that have already been asked today, and the experience I've heard from others. The valve assessment is quite limited. It definitely does go well above FUSIC heart, but maybe in my opinion, it's somewhere closer to a BSc level 1 than BSc level 2, where it's a bit more like just a good look at the valves, a bit of colour. They may add a valvular component later to HD, but that's certainly not been confirmed to my knowledge. So the governance and reliability, I mean, it's a brand new framework. There was only, I think, 7 people that accredited in HD so far. So knowing whether or not that works for patient care and what its vulnerabilities are, time will tell. It's not really a common language between specialties. Kind of everyone knows what a departmental echo offers. I mean, levels of exactly what it offers probably will vary between individuals, but it's certainly not a common language that many people know of. And if you do HD and nobody else has done it, does that make you a local expert? Probably not. And I think probably considering that as you're going through the process and knowing what HD offers is essential to good practice. The reference values are a bit different to BSE. You'll find I've put their reference values on the automated form. I've put the reference values from the HD supplementary data on there where they exist, but some places they don't exist. And in those places, I've put the BSE values. Accreditation process. So the videos from ICS do need to offer more. I think they're in the process of updating them, but at the moment they don't offer enough information to guide you. And that's why I've had to go to other sources like Nepean, who offer fantastic videos online. I think the process is likely to morph with time. Do you want to be one of those people that tests the process or be somebody who takes it on when it's a bit more established? And just as I said earlier, in my opinion, there's some lower hanging fruit that might be able to be added to the data set in the future. And let's see whether that happens. Overall, I really enjoyed going through FUSIC HD. I would recommend it, but it's certainly not the only accreditation process. And if you want to become an expert in echo, then you should probably be considering a more advanced accreditation. Likewise, if you've not got very much time, and HD is definitely more appealing, and it does offer patients, for me, quite a lot that you wouldn't be able to get from just a FUSIC heart level echo. That's it for now. Any questions?